Hello everyone, this is Jessica and welcome to CritIC, the acid-base series. This video will help you determine the cause of a metabolic alkalosis. Let's do this. Metabolic alkalosis occurs when there are either low levels of hydrogen or high levels of bicarbonate, or both. Let's take a look at the causes for low hydrogen first. Note that low hydrogen levels cause a transcellular shift of hydrogen from intracellular to extracellular, which then causes a shift of potassium from extracellular to intracellular. This can also happen the other way around. In other words, metabolic alkalosis and hypokalemia are highly related. Check out my video on hypokalemia for more information. So the first cause of metabolic alkalosis is an intracellular shift of hydrogen, which can be caused by hypokalemia. Another cause for low levels of hydrogen is excessive loss. As with potassium, this can happen through the kidney, renal loss, or through the gastrointestinal tract, extrarenal loss. Gastrointestinal loss is usually through loss of stomach acids, i.e. vomiting or a nasogastric tube, but in some cases also by diarrhea. The mechanism for renal loss of hydrogen is pretty similar to that of renal loss of potassium, so watch the darn video on hypokalemia already. As mineral corticoid excess promotes sodium retention at the expense of potassium, low potassium levels in the distal nephron will cause potassium-hydrogen exchange in the distal tubule. This leads to the secretion of hydrogen and thus metabolic alkalosis. Examples are primary hyperaldosteronism, Cushing's disease, licorice ingestion, etc. These patients typically have high blood pressure. Diuretics like loop and thiazides, and syndromes mimicking those, Barter and Gittleman respectively, can cause metabolic alkalosis as well. As you well know, these diuretics promote sodium excretion, and with that, water. Therefore, more sodium is presented in the distal tubules and collecting ducts. This leads to more sodium reabsorption at the expense of potassium and hydrogen, just like in hyperaldosteronism. The difference is, since these patients are volume depleted, they typically have normal to low blood pressure. Bicarbonate accumulation isn't very common, and you need to remember that the most common cause for metabolic alkalosis by bicarb accumulation is us, when patients have been given a lot of IV sodium bicarbonate. As you've learned in my last video on respiratory acidosis, patients with chronic respiratory acidosis develop a compensatory metabolic alkalosis. Now, if we remove their respiratory acidosis, a metabolic alkalosis will remain. This is called post-hypercapnia metabolic alkalosis, and it is typically seen in patients that are mechanically ventilated after a COPD exacerbation. We mechanically ventilate out their CO2 and metabolic alkalosis remains. You can imagine that it can be difficult weaning these patients off of the ventilator because their respiratory system will want to compensate for that metabolic alkalosis. Diamox, also known as acetazolamide, promotes renal bicarb excretion and can therefore be used as treatment. And then there are two main combined disorders that cause metabolic alkalosis by both excessive loss of hydrogen as well as accumulation of bicarbonate. The first one is caused by dehydration. This type is commonly called a contraction alkalosis, though this term is under a bit of scrutiny. There are several mechanisms contributing to this type of metabolic alkalosis. First, dehydration causes a decrease in glomerular filtration rate, and thus a decrease in bicarb filtration, increasing plasma levels. Secondly, dehydration causes RAS activation, and thus an increase in angiotensin II and aldosterone. As explained before, aldosterone promotes the resorption of sodium at the expense of potassium and hydrogen. Angiotensin II causes hydrogen loss and bicarbonate reabsorption in the proximal tubule. And lastly, chloride depletion, frequently seen in dehydration, causes a blockage in the distal bicarb secretion, leading to an increase in serum bicarb levels, though this last mechanism is based solely on animal studies. So several mechanisms that can be easily summed up as follows. Dehydration causes metabolic alkalosis. Treatment is obviously rehydration with sodium chloride. The second one is the milk-alkali syndrome. This is a condition that causes hyperkalemia, metabolic alkalosis, and renal failure. The name originates from when people were prescribed milk and sodium bicarbonate for the treatment of peptic ulcer disease in ancient history, i.e. some 30 years ago. But now it is more commonly seen in patients that use calcium carbonate, commonly known as Calci-Chew, as a dietary supplement for the prophylaxis or treatment of osteoporosis. Hyperkalemia leads to volume depletion and pre-renal kidney injury, which causes a contraction alkalosis. And the carbonate side of calcium carbonate is an absorbable alkali, thus also contributing to the alkalosis. Treatment is discontinuation of the supplement and excessive rehydration, hyperhydration, with sodium chloride, and close monitoring of urine production. What goes in must go out. If not, consider dialysis. In summary, if you know the workup to hypokalemia, you know most of the workup to metabolic alkalosis. This then also means that for the workup of metabolic alkalosis, you always need to check serum potassium. Fortunately, most blood gas analyzers can give you this automatically. Check your clinic. A few other causes for metabolic alkalosis to remember are the milk-alkali syndrome, dehydration or contraction alkalosis, bicarb infusion, and post-hypercapnia. That's all for metabolic alkalosis. If you like the video, help the channel out by sharing it on your social media. Thanks so much.